I'm Dr. Victoria, and this is George.
Today, we are going to talk about acute pancreatitis. Earlier today, George was having lunch when he started vomiting profusely. He had nausea and he must have vomited at least 20 times. And the abdominal pain, he called it a 10 out of 10 pain for sure. I told him he better go to the emergency room right away. What is happening to George is that with this rapid onset of pain, he has acute pancreatitis. We want to take a look at the anatomy of where the pancreas lies when we consider the different reasons for acute pancreatitis. From the nearby gallbladder, we can have refluxing bile get into the pancreatic duct, or from a stone blocking the pancreatic duct or common bile duct, a cancer at the head of the pancreas that is occluding the flow out of the pancreas. Alcohol likely increases the synthesis of digestive and lysosomal enzymes, triglycerides greater than 1,000 milligrams per deciliter, a genetic mutation, whether it is a gain in function or merely lowers the threshold for pancreatitis from other causes, medications that can injure the pancreas, and blunt or penetrating trauma can damage the pancreas, just to name a few. On exam, patients with pancreatitis may have mild or severe pain depending on the severity of the disease. In severe pancreatitis, you may see fever, tachypnea, hypoxemia, hypotension. There may be tenderness in the epigastric region, or in severe cases, diffusely all over the abdomen. There may be abdominal distension and hypoactive bowel sounds. If there were pancreatic necrosis, you may see some of the discoloration around the periumbilical region, Cullen sign, or at the flank, Gray-Turner sign. If there is a stone in the common bile duct, cholelithiasis, or inflammation at the head of the pancreas, there can be jaundice. Our laboratory exams will evaluate several things. We will look for pancreatic enzymes and products. Serum lipase is elevated earlier and lasts longer than serum amylase, so it is usually the more common and helpful test to use. Markers of immune activation include elevated C-reactive protein. You may notice leukocytosis and elevated hematocrit due to hemoconcentration from the extravasation of intravascular fluid as it moves into the interstitial space. There may also be elevated blood urea nitrogen, hypocalcemia, and hyper or hypoglycemia. We will also want to get a lipid panel, but we will talk about that reason later. There are several modalities we can use to image the abdomen. Normally, we will start with a CT and right upper quadrant ultrasound. If these are inconclusive, we may transition to an MRI with MRCP. And then, depending on the results, we may need to do an ERCP. Abdominal and chest x-rays may show elevation of the hemidiaphragm, pleural effusions, basal atelectasis, pulmonary infiltrates, or acute respiratory distress syndrome. We may be able to see peripancreatic fluid collection. With abdominal ultrasound, you may see a diffusely enlarged and hypoechoic pancreas. We might be able to see gallstones in the gallbladder or bile duct. Often, gas in the bowel makes it difficult to really evaluate the pancreas. Abdominal CT may show acute interstitial or edematous pancreatitis. You may see focal or widespread enlargement of the pancreas seen with contrast. If there is necrosis, you will not see any enhancement after giving IV contrast. If evaluating with a CT with contrast 3 or more days after the onset of abdominal pain, you will be able to see the changes from pancreatic necrosis. It takes a bit of time. Sometimes we can see common bile duct stones or pancreatic masses. With MRI, we would like to do a magnetic resonance cholangiopancreatogram, MRCP. This is sensitive for early diagnosis of acute pancreatitis versus CT with contrast, and allows us to visualize the pancreatic and bile ducts with greater clarity. Finally, we have endoscopic retrograde cholangiopancreatogram, ERCP. It is both diagnostic and therapeutic, since you enter with an endoscope and are able to remove any stones that are present as you see them. To diagnose acute pancreatitis, we need 2 out of 3 criteria: acute onset of persistent and severe epigastric pain that often radiates to the back, elevation of serum lipase or amylase 2 to 3 times greater than our normal upper limit, and 3, imaging results that show characteristic findings of acute pancreatitis. This can be CT, MRI, or ultrasound. If we have the appropriate symptoms and elevated enzymes, we do not need any imaging to establish the diagnosis. If the pain is not characteristics or enzyme levels are less than 3 times the upper limit of normal, or we're just uncertain, it is important to do CT with contrast to exclude other causes. An alternative for someone with an allergy to contrast or renal failure would be an MRI without gadolinium. Our differential diagnosis is varied and includes peptic ulcer disease, a problem with the gallbladder, whether it is cholelocholithiasis or cholangitis. While an obstruction can be solely related to the gallbladder, it can also lead to pancreatitis. With cholecystitis, we will likely see Murphy's sign, a perforated viscus, and intestinal obstruction, mesenteric ischemia, or hepatitis. The etiology for the pancreatitis can be several things, including but not limited to mechanical, such as a gallstone, biliary sludge, a pancreatic or periampular cancer, a duodenal stricture or obstruction, toxic, alcohol, scorpion venom, organophosphate poisoning, metabolic, hyperlipidemia, hypercalcemia, drugs, metronidazole, tetracycline, furosemide, thiazides, azathioprine, valproic acid, salicylates, calcium, Ozempic, and estrogen. Viral, mumps, Coxsackie virus, hepatitis B, cytomegalovirus, varicella zoster, herpes simplex virus, or HIV. Bacterial, mycoplasma, legionella, leptospira, or salmonella. Fungal, like aspergillus. Parasites, including toxoplasma, cryptosporidium, ascaris. Trauma, blunt or penetrating abdominal injury, or something happening during surgery or ERCP, during a sphincterotomy. Vascular ischemia, atheroembolism, vasculitis such as polyarteritis nodosa or SLE, a genetic mutation, or in the setting of pregnancy, renal transplant, or alpha-1 antitrypsin deficiency. Initially, for treatment, we want to start with fluid replacement. We will hydrate at a rate of 5 to 10 milliliters per kilogram per hour of something like normal saline or lactated ringers. It is important that we hydrate in the initial stages in the first 12 to 24 hours, as this helps decrease morbidity and mortality. We also want to control our patient's pain. This is usually the most pressing concern. Opiates are safe and effective at providing pain control, and often hydromorphone or fentanyl are used. As well, meperidine or morphine are alternatives. We should monitor the patient closely for that first 24 to 48 hours. We will want to check their vital signs. We want to make sure they have good urine output. If we are giving a lot of fluids, it is important to monitor their electrolytes and correct low calcium or magnesium. We will watch serum glucose levels, blood glucose greater than 180 to 200 milligrams per deciliter. This should be treated since it can increase the risk of secondary pancreatic infections. Most patients do not need antibiotics and should not be given them prophylactically. If there is an extra pancreatic infection, whether this is the bloodstream, pneumonia, or a urinary tract infection, we can then start antibiotics. If the patient is on a medication that can lead to pancreatitis, this should be discontinued. If there's a gallstone blocking the biliary tract or ampulla vater, some of these pass on their own, and others, they will need to be removed via ERCP. If a stone is the culprit, the patient will likely need a cholecystectomy and get that gallstone taken out. Otherwise, they are at risk of having the same thing happen all over again. If the culprit is elevated triglycerides, usually in a concentration greater than 4,000 milligrams per deciliter, we can treat this with something called apheresis, where we filter the blood, or through insulin therapy, where we can lower the triglyceride level, but most importantly, it helps affect several cells. Reversal of fatty acid release from adipocytes, increased intracellular triglyceride generation within adipocytes, and promote fatty acid metabolism in cells sensitive to insulin. Moving forward, it will be important that these patients have maintenance triglyceride levels below 500. If the culprit is due to alcohol, they will require an alcohol intervention, similar to what George has been through before. I sure am glad that George stopped drinking. In most patients, they will recover in 3 to 5 days without complication or organ failure. For the 20% with moderately severe or severe acute pancreatitis, there may be systemic or local complications, including organ failure. So, after all the tests that happened in the ED, it looks like George's lipase was through the roof, and he had a stone coming from his gallbladder to block the ampulla vater, which caused some inflammation at the pancreas. He is going to have to stay at the hospital at least overnight so he can have an ERCP performed to remove the stone. And George, he is going to have a chat with a surgeon because he is going to have to get his gallbladder taken out. That is, if he doesn't want this to happen again. It looks like his gallbladder is just full of gallstones. He can wait for his pancreas to calm down before that procedure. He is just relieved that he got some pain medication so that he can think straight. Thank you for joining me today, my healthcare team. I hope that you will join us next time to see what George gets up to next. Bye-bye.